Next, I invite Dr. Dhanya to speak on non-surgical treatment options in diabetic retinopathy. Dr. Dhanya is the Senior Associate Professor in Government Medical College, Ernakulam.
Good morning, one and all. And thank you, KSOS, for giving me this opportunity. My topic for today's discussion is non-surgical management of diabetic retinopathy. As you all know, it is one of the leading causes of blindness worldwide, and PDR and diabetic macular edema being the retinal complications which results in irreversible blindness in diabetes. And what are the risk factors for this? Raised blood glucose, lipid and triglyceride levels, hypertension, anemia, advanced diabetic nephropathy, and pregnancy being the risk factors associated with progression of diabetic retinopathy. And medical management, I'll be telling in a nutshell. The first thing you have to do is a systemic control of diabetes mellitus and the associated risk factors. And in mild to moderate non-proliferative diabetic retinopathy with no macular edema, you have to observe the patient regularly, screen, and to find out whether there is any progression in the diabetic retinopathy. And in severe NPDR and proliferative diabetic retinopathy, you have to consider pan-retinal photocoagulation. And diabetic macular edema, you can do either a focal or grid photocoagulation, intravitreal anti-VEGF therapy, or intraocular steroids, depending upon whether it is a center involving or a non-center involving macular edema. And control of the risk factors, as I told you, the intense glycemic control brings down the progression of the microvascular complications, and a tight control of hypertension. And recently, 2 pivotal studies have published regarding the beneficial effects of fenofibrate and candesartan for the treatment of hyperglycemia and triglyceridemia, which can reduce the progression of diabetic retinopathy. You can see in the picture how drastically the hard exudates and the hemorrhages have been decreased after the strict metabolic control of statins with statins and antihypertensives. And next, in detail of proliferative diabetic retinopathy, a non-high risk PDR without diabetic macular edema, you have to do a 2 to 4 monthly follow-up, and immediately you have to do a pan-retinal photocoagulation if high risk PDR develops. And high-risk proliferative diabetic retinopathy without any macular edema, also you have to do a pan-retinal photocoagulation. And PDR with diabetic macular edema, you have to do a combined approach with anti-VEGF and pan-retinal photocoagulation. So this is a flowchart depicting how to manage the proliferative diabetic retinopathy with diabetic macular edema, without, and with fractional diabetic retinopathy. You can see in the first with DME. If it is a focal DME, you have to consider a focal laser therapy and followed by PRP. And if once the DME regress, then yes, you have to observe. If it's not regressing, you have to do an anti-VEGF or Dexoran implant, and after that you have to schedule the pan-retinal photocoagulation. And if it is without DME, you have to do an immediate PRP if it is feasible. Then if it is not feasible, then you have to do an anti-VEGF therapy. And fractional diabetic retinopathy with or without vitreous hemorrhage, then you have to do a consider pars plana vitrectomy for this patient. Okay, so what are lasers? These are time-tested, evidence-based fundamental treatment for diabetic retinopathy. A rapid strides makes the laser treatment more selective and targeted and less destructive. Otherwise, it will cause destruction of the photoreceptors and can result in the night vision problem or color blindness or contrast sensitivity post-laser. And this is not associated with serious complication as in for anti-VEGF. So indications of lasers other than PDR in diabetic retinopathy is DME. If it is a non-center involving, you can use either focal or grid lasers. And in advanced diabetic eye disease, you can do an endolaser photocoagulation as a part of surgical management. PRP can also be done, has to be considered in a cases of non-high risk PDR. The certain indications are if you feel that the patient will not come for follow-up, if there is a limited healthcare access for the patient, and in an old patient with type 2 diabetes mellitus, one-eyed, and pregnancy patients with pregnant patients and patients who are impending cataract surgery. How do this act? They destroy the hypoxic retina and improves the oxygen perfusion from the choroid to the viable retina. This is the ETDRS protocol to how to do a PRP. Argon laser or double frequency ND arc lasers are usually used for this, and you have to do about 1200 to 1600 burns, about 1.1 to 1.5 burn width apart. The size of the burns can be between 200 to 500 microns, duration 0.1 second exposure, and intensity should be between 200 to 500 millivolt. And this is a picture post PRP. You can see the white burns in the retina where the lasers have been done. And the area where the clear area, that is usually these lasers are usually done in between, covering the area between major arcades posteriorly and the equator anteriorly. Settings for focal laser is about 50 to 100 microns, 0 to 100 milliseconds, just to whiten the microaneurysm. About 15 to 20 spots are usually given, and this is usually given in diabetic macular edema. I told you this non-center involving, okay. And these are the types of pan-retinal photocoagulant advancements in types of laser: conventional laser, pattern scan laser, navigated laser, and micropulse laser. Of this, what is the importance of the pattern scan laser is that multiple burns are delivered in less time. So it is more comfortable for the patient because the exposure to light is minimal. And the navigated lasers with computer assistance, it tracks the retinal eye movements and automatically it will readjust and minimizes the exposure to light. And this also is more comfortable for the patient. And micropulse lasers are subthreshold lasers which spares the choriocapillaries and photoreceptors with no visible burns. And so the visual fields and the contrast sensitivity post laser is better and more accepted by the patient. The complications in the anterior segment and posterior segment you must be knowing, and main complications I feel is you should know is a color vision and contrast sensitivity and decreased night vision and permanent visual field defects post laser. And in the posterior segment may be ERM, choroidal neovascularization, choroidal detachment, and PVD. Next, I am going into detail with the treatment of diabetic macular edema. As you all know that it is a retinal thickening by accumulation of the intraretinal fluid in the inner and the outer plexiform layers of the retina at the posterior pole. The international classification of severity of the diabetic macular edema, you should know how to know the management. If DME is present, you should look for whether it is a mild, moderate, or severe. If it is mild, the hard exudates or retinal thickening will be away from the macula. If it is moderate, hard exudate and RT will be approaching the center but not involving. And severe means center involvement, retinal thickening with hard exudates will be present. And how do you manage the diabetic macular edema? All the patients with diabetic macular edema planning for intravitreal injections should take an OCT and also, if needed, fundus fluorescein angiography. OCT you have to look for in retinal thickening, foveal contour, VMT, neurosensory detachment, disruption of the inner retinal layers. And fundus fluorescein angiography you have to do whether the loss of vision is disproportionate to the clinical picture. If you think that it is an ischemic maculopathy, if you suspect neovascularization, and also for mixed retinopathy and non-responders to treatment. Other systemic investigations you have to do as following: FBS, PPBS, renal function, HbA1c, BP and lipid profile, and whether the patient on glitazones or not. And Dr. Deepa has already covered about what is center involving and non-center involving. So treatment of diabetic macular edema can be based on whether it is involving the center or not involving the center. And if it is not involving non-center involving, it can be not threatening the foveal center or threatening the foveal center. If it is not threatening the foveal center, no ocular treatment is required at time, but strict metabolic control of diabetes mellitus is needed. And if it is threatening the center, you have to do a focal photocoagulation to treat all the microaneurysm associated with the area of macular thickening, or gentle modified grid to the areas of thickening. You should avoid treatment of nerve fiber layer hemorrhages as well as blot hemorrhages. Now coming to the treatment of the center involving diabetic macular edema, the mainstay of treatment is by using intravitreal injections like ranibizumab, bevacizumab, aflibercept, and intraocular steroids. Mainly the intraocular steroids you give for poor responders to anti-VEGF as well as the patients with high-risk diseases like myocardial infarction and CKD. The intravitreal injections, they reduces the retinal neovascularization by inhibit VEGF, as you know, but you need repeated injections, and the patient compliance and adherence to the therapy is very crucial for the success of this treatment. This is the anti-VEGF spectrum you should be knowing, and dosage is different for all. And bevacizumab is an off-label use with increased risk of hypertension, stroke, and MI. Aflibercept has got a higher affinity, 200 times that of ranibizumab, but it is and the newer anti-VEGFs are brolucizumab and faricimab. The complications of anti-VEGF affects the renal status of the patients with diabetic retinopathy. Either a new kidney damage or progression of the existing renal damage can be there. And how do you give anti-VEGF injections? Monthly injections involves larger number of injections. It is not practical. How do you reduce that? So you have to do a loading dose followed by pro-nata, that is pro-nata regimen as and when required, and 3 loading dose followed by PRN for ranibizumab, and 5 loading dose followed by fixed monthly regimen for bevacizumab. Treat and extend is another modality of treatment which start with a monthly loading dose till vision improves or OCT thickness do not improve further, and follow-up is increased more than a month by 1 or 2 weeks, and if vision is not dropping, call after 8 weeks, and thus injections can be reduced to 5 per year. And non-responders, eyes which do not show more than 20% of reduction in CRT or no vision improvement after 3 injections, you can switch on to treatment to other anti-VEGFs or steroids. Intravitreal steroids, common ones are triamcinolone, dexamethasone, and fluocinolone. It is the first choice in patients with ISD, CKD, CVA, where anti-VEGF are not safe. And the special conditions in which you see diabetic macular edema. In pregnancy, anti-VEGF is not safe. In late pregnancy, observe till delivery or treat if not responding spontaneously. In center involving DME in early pregnancy, you have to give intravitreal steroids. And DME in uncontrolled hypertension, you have to control the hypertension and treat only if DME persists. And CKD, you have to do anemia will be the contributing factors and correction should be done. Ischemic optic neuropathy can also be the cause of non-improvement. And so etiology of DME is multifactorial, needs tailor-made treatment. And other indications of intravitreal steroids include presence of clump of hard exudates or intraoperatively for triamcinolone acetonide assisted vitrectomy. And so the take-home message in of my talk is early detection of diabetic retinopathy by regular screening has improved the visual prognosis in diabetes mellitus. And modern advances in the medical management of diabetic retinopathy has brought down the need for surgical intervention. And so prevention is always better than cure. Thank you.
Thank you, madam, for that systematic presentation, compiling all modalities of medical treatment in such a short time.